welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today, we are starting off with Ethan Meyer, who is a PGY2 in critical care at Northwestern Memorial Hospital. He will be presenting a journal club on antithrombin 3 levels and outcomes among patients with.
Wanted to start by presenting a little bit of background information. So antithrombin is a natural anticoagulant, and as you can expect from the name, it inactivates thrombin. Heparin products are actually cofactors of antithrombin that increase activity, and they actually increase activity by nearly 1,000-fold. Patients with antithrombin deficiency are at heightened risk for VTE, and heparin also is not as efficacious due to the mechanism of action in patients who are antithrombin deficient. And surgery and trauma can lead to an acquired antithrombin deficiency, and this is due to a couple different mechanisms. So the first one being dilution with resuscitation, and then active consumption due to bleeds that may be going on and clot formation. Because of these two factors, there are high rates of DVT and other VTEs within the trauma population despite prophylaxis. So this here is the coagulation cascade. You can see that when you get to the end, you have thrombin, which converts fibrinogen to fibrin, which is the actual substance that forms our clots. And where antithrombin acts would be at all of these different factors within the cascade. Primarily, the two sites of action where it has the most action would be at factor 10A and at thrombin. But through all of the antagonism of the coagulation cascade that it provides, it is a anticoagulant. So I have kind of a conglomeration of trauma surgery and hematology guidelines that I looked through, and a few recommendations or things that were called out from those various guidelines were that antithrombin deficiency is considered high risk for VTE recurrence. And VTE prophylaxis is recommended within 24 to 48 hours after trauma, provided that hemostasis has been achieved and it's safe to start. And the primary recommendation would be for low molecular weight heparin, such as enoxaparin, with a dose of 40 milligrams every 12 hours for most trauma patients. Some patients that you might consider alternative agent or different dosing would be patients who are greater than 65 years of age, patients who are less than 50 kilograms, or who have a creatinine clearance less than 60. You may change your dose or change your agent in those patients. So now going into an overview of the article. So this was a single center prospective observational cohort study of trauma patients that evaluated the association of antithrombin 3 levels with various clinical outcomes. This was completed at a level 1 trauma center and an academic medical center within an urban area. The objective of the study was to assess if changes in antithrombin 3 levels were associated with thrombohemorrhagic complications in trauma patients. And antithrombin 3 levels were collected at several time points between admission and day 6, with those specific time points being at admission, 8 hours, 16 hours, 24 hours, 48 hours, and then day 3 and 6 post-admission. Although I will call out that not all patients received collection of antithrombin 3 at each of these time points. And then they defined antithrombin 3 deficiency as an assay with less than 80% activity. So within their study population, they had a total of 292 patients, and their inclusion criteria was any patient who presented with a trauma with any one that met any one of these criteria. So we have a Glasgow Coma score less than 12, intracranial hemorrhage, systolic blood pressure less than 90, any penetrating injury to the neck, torso, or groin, amputation proximal to ankle or wrist, uncontrolled external hemorrhage, 2 or more long bone fractures, pelvic fracture, paraplegia or quadriplegia at admission, burns that were less than 20% surface area of the body, 3 or more rib fractures, and then any solid organ injury. So pretty wide variety of patients that they pulled in with trauma with various characteristics and injuries. Their exclusion criteria included any patients who were discharged from the emergency department without being admitted, those less than 18 years old, those who received an invasive procedure or transfusion prior to arrival, as this may confound their antithrombin 3 levels. If there was a failure to draw initial labs within an hour of presentation, and then any prisoners or participants in other studies were also excluded. For their methods, they collected laboratory data, which was collected at the same time points as antithrombin 3. This included your CBC, your APTT, anti-10A, PT, and INR. And all patients received enoxaparin 30 milligrams twice daily per their institutional protocol once no contraindications were met. They also performed protocolized DVT screening at day 3, day 7, and then weekly thereafter. And that was with Doppler surveillance. The decision to evaluate for PE or hemorrhage was made by the primary treatment team based on the patient's clinical status. And then clinical outcomes were tracked for the duration of the hospital admission. I also wanted to call out the various stats that they ran. So for quantitative and normally distributed data, they used a t-test. Quantitative and non-normally distributed, the Wilcoxon rank sum test. Categorical data with the large sample size, they use the chi-square test, and then categorical data with small sample size, they used Fisher exact test, which are all appropriate statistical tests based on the data. Clinical outcomes, so these were all studied as a primary outcome. However, it was the association of the antithrombin 3 levels with any of these outcomes. So ventilator-free days, hospital ICU-free days, intracranial hemorrhage, progression of intracranial hemorrhage, and then other hemorrhage, which was defined as a systolic blood pressure less than 90, and the need for blood transfusion or imaging that was consistent with ongoing bleeding, deep vein thrombosis, pulmonary embolism, and mortality. With the baseline characteristics, I will give you a moment to look at these. One thing I did want to make note of, so the pre-hospital fluids, more patients who were antithrombin deficient received fluids prior to hospitalization. And then I also wanted to highlight that over 90% in each group were blunt trauma injuries. So a significantly high percentage and very few patients in this population had penetrating trauma injuries. And then 58.2% of the patients in the full population received enoxaparin prophylaxis at some point during their admission. Looking at additional baseline characteristics, so these are some of our severity scores. I specifically wanted to call out the percentage of level 1 versus level 3 traumas. So within the non-deficient group, it was only 10% level 1 traumas and roughly 70% level 3, versus in the antithrombin deficient group, we had a significantly higher percentage that were level 1 and a lower percentage that were level 3. Moving into the results, so a few things that I wanted to call out. These are the statistically significant values. So the ventilator-free, hospital-free, and ICU-free days were all significantly more in the non-deficient group. So these patients that were not antithrombin deficient spent less time on the ventilator, less time in the hospital, less time in the ICU. progressive intracranial hemorrhage and other hemorrhage were both increased in the antithrombin deficient group. And then with intracranial hemorrhage, if you look at the right side of the graphic, so this is looking at the subset of patients who were antithrombin deficient, and those who were not deficient at baseline but progressed to have deficiency later in the timeline were more likely to have ICH. It was more associated with ICH than those who were already deficient at baseline. And then in terms of mortality, we also see that the antithrombin deficient group had higher mortality, and those who were not deficient at baseline but became deficient over the course of their hospitalization also had an increased mortality compared to those who had that deficiency at baseline. So in terms of critique of the study, some of the strengths, the rates and timing of antithrombin 3 were consistent with the reported prevalence in trauma. So we expect the proportion of patients with trauma who have antithrombin deficiency to be around the 50% mark, which is what we saw here in this population. This was also a prospective study, which was a strength, and then it was a relatively externally applicable trauma population. The one caveat was that there was a lot of blunt traumas, so this may not be as applicable for your penetrating traumas, just given it was a very low percentage. Some of the limitations are that it was a single center study. No causation conclusions can be made. It was just an associative study. In addition, I think the antithrombin 3 deficient group having more severe injuries, which was highlighted by the percentage of level 1 traumas versus level 3, as well as our Glasgow coma score and injuries severity score indicating more severe injuries within the antithrombin 3 deficient group. I think the baseline characteristics may potentially skew those outcomes. Not all patients contributed samples at all time points. And then they didn't do a great job of commenting on the use and timing of thromboprophylaxis. They mentioned the overall percentage of patients who received it, but they didn't differentiate between the two groups, as well as at what time point did this thromboprophylaxis get added on. Another thing that they didn't mention was if patients were on anticoagulation or on antiplatelet agents at baseline, which also potentially would affect some of these outcomes as well. So the author's conclusions were that antithrombin 3 deficiency was associated with greater illness severity and worse hospital outcomes. Higher incidence of progressive hemorrhage highlights potential differential role for antithrombin 3 in trauma. When presenting the background, I talked about an increase in thromboembolic events, but they showed increased thrombohemorrhagic events. And actually, the majority of the deaths within this population were due to either progressive intracranial hemorrhage or anoxic brain injuries. And what this may suggest is that antithrombin may provide protection from endothelial damage as well as inflammation, in addition to its normal function within the coagulation cascade. So potentially also increased risk for bleeding events in addition to the increased risk for thrombotic events. Also, that monitoring of antithrombin 3 levels in trauma patients may be warranted, and this might help us stratify our risk for various trauma patients. Moving into my takeaways from this study, I think it's difficult to draw any significant conclusions because this was an associative study. However, low antithrombin markers potentially is a marker of a more significant injury. And we already kind of know that trauma patients are high risk for both thromboembolic and hemorrhagic complications. I also think that other markers of trauma severity are likely an appropriate predictor of poor outcomes, and getting regular antithrombin levels on patients may not give us that much more information that's clinically useful. Looking at my specific institution's lab policies. So we actually only run the antithrombin levels on Tuesdays and Thursdays. Because of that, I think it makes it very difficult to use this test to drive clinical decision making. And I think the TAG or ROTEM tests give a more complete assessment of coagulation processes in each individual patient and do a better job of guiding clinical decision making in terms of what products we might be resuscitating the patient with. And I think overall antithrombin 3 monitoring is likely to change the management of this population at this time. And I don't think that this study provides enough support that I would consider using antithrombin levels more regularly to help with stratifying patients based on that risk of thrombotic and hemorrhagic complications. At this time, I will open it up for any questions or discussion.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.